pleasure to welcome today's Grand Round speaker, not just because he's an accomplished physician scientist in our field, but also he's a dear friend and a former colleague. Until 2022, we had the privilege of actually having Dr. Brandt here at RWJ. Then, in a sudden move, he decided to trade in our bagels and coffee for a skyline view and a new leadership role in New York. But we try not to hold that against him. Dr. Justin Brandt is now the Director of Maternal Fetal Medicine and Fellowship Director at NYU Langone Health, where he serves also as an Associate Professor at NYU Grossman School of Medicine. His clinical and academic impact spans far and wide, from obstetric ultrasound. He was actually the Director of Obstetric Ultrasound here, to maternal and fetal complications, bibliometrics, which is his passion, and inclusive research practices. He has authored over 100 peer-reviewed abstracts and manuscripts, which makes me think, I'm convinced actually, that he writes faster than most of us can read. Justin is not only a respected voice in maternal fetal medicine, but also a devoted educator with multiple teaching awards to his name. He has served nationally on key SMFM committees for diversity and equity. He's actually the vice chair of the committee right now, and also the publications committee. Today, he's here to speak on a topic that remains an important unsolved challenge in fetal medicine. One, I hope that it will inspire discussion, reflection, and hopefully new direction for research. Please join me in giving a warm welcome back to our friend and colleague, Dr. Justin Brandt.
Thank you, Dr. Sharma. Can you hear me okay?
Yeah, perfect.
Perfect. It's great to be with everyone this morning. I love Dr. Ebert's M&Ms. Dr. Lopez did a great job with the case this morning. And what I really enjoyed was the engagement with the faculty. I wish at NYU we could engage the faculty and ask so many questions and have such a robust conversation in our M&Ms. So that was just really great to see. So thank you for letting me be a part of that. I'm going to talk.
Dr. Brandt?
Yes?
Oh, so sorry to interrupt. You are sharing presenter view. I don't know if you want to click the share arrow and share the other one, or just on PowerPoint. Yeah, there it is.
That?
Perfect.
Thank you.
Sorry
Thank you for pointing that out.
interrupt.
No, thank you for pointing that out. So today I'm going to talk about congenital heart block, which is a relatively new academic interest of mine, largely driven by my engagement interaction with faculty at NYU in our rheumatology department. But I will jump in and share with all of you. I have no financial conflicts of interest. I forgot I wanted to give you a little bit of background before I jump into my talk about what I've been doing since leaving Rutgers 2 years ago. I jumped over to Manhattan, where I oversee MFM operations at Tisch, and my team also covers both Bellevue Hospital and NYU Langone Hospital in Brooklyn. We do about 10,000 deliveries annually in our 53rd Street Ambulatory Care Center. We do over 30,000 ultrasounds. Very, very busy, high acuity practice. I have a great team. We have 12 MFMs, including myself, starting in September. One of our fellows is joining the faculty. We have expertise in research and fetal echo, excellent teachers. I've been very, very fortunate to work with this team. I became the fellowship director in December, which was a little bit unexpected, but also has been a great adventure. We have 2 fellows per year. This is just a picture of my team celebrating our graduating fellows last year with family and friends. Some of the sort of key achievements that we've had over the last 2 years, I want to just share with all of you. One of our faculty members successfully earned a Career Development Award at KO8. We are super excited and proud of her and all of her work. Her name is Christina Penfield. We joined the Perinatal Research Consortium as my excuse to keep close ties with Dr. Nanth and Dr. Rosen. We expanded fetal echo. Our cardio-obstetrics team has also expanded, and we formalized our placenta accreta program, largely after we snatched a prominent GYN oncologist from Colombia named Fadi Coricolado. We've strengthened bonds with Long Island, our Long Island campus. This is a picture of our team doing a laser ablation for a complicated monochorionic gestation with twin-twin transfusion syndrome. And very excited that come September, we will have a new member of NYU Langone, Jose Piero, who's a prominent fetal surgeon currently at Cincinnati Children's, who's coming to join our team. And in September, he will start to bring fetal surgery, including spina bifida repair, to Manhattan. Very, very excited about this. I could not be where I am today if it weren't for the opportunities and the privileges and experiences that these three these three gentlemen gave me while I was at Rutgers. I am very much thankful to everyone at Rutgers, but truly indebted to Dr. Nant, Dr. Rosen, Dr. Sauer, for giving me all the opportunities that allowed me to spread my wings and go to NYU. So thank you, thank you, thank you. All right, now the presentation. This is my outline. We're going to talk about 3 parts. Number 1, when congenital heart block occurs, what can we do? What are the outcomes? The second part will be a discussion about people with SSA antibodies who are at risk for congenital heart block. How do we approach those cases? And then finally, we'll talk about patients who have a prior pregnancy complicated by congenital heart block. They are currently pregnant. What is our best management approach and what is on the horizon? And I'm excited to share some new research that we're planning to do in this area. So we'll get started with part 1, when heart block occurs. So I want to share a recent clinical case that I encountered. A patient presented for her anatomy scan. It was actually a follow-up at 20 weeks to our Long Island campus. Really no medical or significant medical issues. She had 2 prior full-term pregnancies, both complicated by severe preeclampsia. She had a personal history of right bundle branch block, but no known rheumatologic or autoimmune diseases. She was taking low-dose aspirin, a prenatal vitamin. She had been seen 2 weeks prior in our unit for an anatomy ultrasound, but at 18 weeks, some structures were incomplete. It was a normal heart rate at that time, normal anatomy, but the patient was recommended to come back in 2 weeks to complete the survey. When she came back to the office, we were very much surprised to see that the heart rate was in the high 70s. Normal heart rate is 110 to 160 for a fetus. Closer to 160 is what we would expect at this gestational age at 20 weeks. We saw complete disassociation between the atrial and the ventricular rates, and this was a 3rd degree or complete AV block. The heart assessment was challenging, but appeared to be structurally normal. There was no congenital heart disease outside of the finding of the very low heart rate. There was no high drops. So this fetus at this moment was tolerating this junctional ventricular rhythm in the high 70s without high drops. So we immediately suspected, our team suspected, that this was a manifestation of a neonatal lupus, a cardiac manifestation. In the context of a structurally normal heart, we immediately were thinking about autoimmune etiologies. So our team ordered SSA and SSB antibodies, which came back positive. The patient was started rather quickly on Plaquenil. They tried at Long Island dexamethasone and IVIG in the context of 3rd degree heart block, complete heart block. These are not interventions that are effective. It was a salvage attempt. And ultimately, the patient was transferred to our team in Manhattan for a TISH delivery. This patient got multidisciplinary care with my team in MFM, with Pete's cards and rheumatology. But despite all of that we have done, the heart block persisted. We monitored the fetus closely for signs of heart failure and high drops. We did not see either. Over time, the heart rate slowly dropped down to the 50s, but was apparently tolerating this rhythm and this rate. But then at the end of her 35th week, she developed vaginal bleeding. We were concerned about an abruption. We were unable to monitor the fetus well using external monitoring, and we performed a cesarean delivery at 35 weeks and 5 days. Good news to report about this, potentially sad and serious case. The patient had an uncomplicated C-section. the baby was born at 5 pounds and 5 ounces, was doing relatively well initially with medical care and optimization. And baby Mikey was able to get a pacemaker. This was one of the smallest pacemakers, or is the smallest pacemaker in existence right now. Only 50 have been used in the United States. It's the size of a vitamin. And this is a picture of Mikey with his mother and Dr. Kumar, Dr. Tan from our peds CT surgery team. And the baby did quite well. But this is not always how these cases go. So we're talking here about neonatal lupus. It's a rare and serious complication of lupus. It affects fetuses and offspring exposed to antibodies that are transplacental from the mom, SSA and SSB antibodies. Some patients don't know they have lupus and may not actively have lupus, but they certainly are at risk for developing it in the future. Manifestations of neonatal lupus are listed here. You have cutaneous lesions, skin lesions, heart block, obviously, which we're talking about today, anemia, hepatitis, thrombocytopenia. What's interesting about these placentally mediated impacts or manifestations is in the baby exposed to them in utero, typically these symptoms will resolve at 2 to 3 months of postnatal life. But that is not the case for congenital heart block. These antibodies, SSA antibodies in particular, are tropic for myocardial tissue and the conduction system. It leads to changes like inflammation, fibrosis, scarring, and calcification, which result in a permanent injury to this conduction system that leads to, if the baby survives into childhood, a permanent conduction problem. Congenital heart block, I've used the term already. Really, it's just a delay or interruption of the electrical impulses that originate in the atria and go towards the ventricles. You have a mild heart block with first degree, where you just have delayed conduction. In second degree cases, the conduction from the atria to the ventricles can be prolonged, in some cases intermittently blocked totally. And then third degree is when we have complete AV block, and you get this junctional escape rhythm, which is often in the 60s to 80s. And, that's when babies are at highest risk for complications. Often when heart block occurs in utero, it's third degree. That's when we catch it. Most cases of heart block in utero are due to SSA antibodies. 100% of cases, basically 100% in the context of a structurally normal heart, are due to these antibodies. Again, this typically manifests between 15 and 25 weeks. Here's just a little insight into the mechanism. These antibodies go across the placenta through Fc receptors in the placenta, and they bind to cardiomyocytes that are already undergoing apoptosis as part of the normal remodeling process. This leads to the release of tumor necrosis factor by macrophages and significant fibrosis in the AV node. These antibodies, though, have a second impact. They can actually inhibit calcium channel activation and further disrupt AV conduction. So it's a double hit driven by these antibodies, leading to congenital heart block. This is just a picture of what heart block looks like. This is M mode or motion mode. And you can see the ventricular rate on the top, and you can see the atrial rate on the bottom. There's no relationship here. It should be 1-to-1, but rather here we have a ventricular rate in the 50s and an atrial rate in the 140s, indicating here, in this case, a complete AV block. These are the manifestations. Really varies according to when this presents in utero. Babies, by the way, who are delivered preterm prior to 34 weeks have over 50% mortality. If we can keep these babies with heart block pregnant beyond 34 weeks, their outcomes are much, much better. But high drops in preterm birth and fetal death are major, major concerns. When congenital heart block occurs, we really have no effective interventions. Nothing has been shown to reverse third degree block. Nothing has been shown. Once it develops, it is irreversible. In the case I talked to you about, we did treat this patient with IVIG and Plaquenil, Dex. This was a salvage therapy. This is actually before I was involved in her care directly, but we know it's not effective. So we shouldn't do that. We don't need to do that. We want to see if we can catch these patients before heart block develops. And that's what we're going to talk about next. Maybe there's benefits there. But when heart block develops, we're really stuck with observation and monitoring. We're looking for signs of heart failure, signs of high drops. And then the idea is to deliver before demise occurs. So that's where we are with patients who have congenital heart block, third degree. Currently, we don't have great options, and it's expectant. So let's switch gears now and talk about those patients who are at risk for congenital heart block. This patient, it comes to the office with a history of lupus or Sjogren's. You check SSA, SSB antibodies, and they're positive. What do we do with this? Well, we typically do fairly generic counseling. We tell them the risk of developing congenital heart block is about 2%. In pregnancy, we talk about potential manifestations of neonatal lupus like we have addressed. By the way, those manifestations may occur in anywhere from 10 to 25% of babies exposed to these antibodies. And then we get into a very uncomfortable discussion about conflicting professional society recommendations. Do we do PR interval monitoring? Do we do home DOP tone monitoring? Are we going to treat? It's so confusing. It ultimately results in an individualized plan with lots of uncertainty. And I always feel a little bit uncomfortable in these cases because there's just so many questions. But I'm going to address two of them and give hopefully some insight into how we can maybe better manage these cases. So first of all, are all patients with anti-Ro antibodies, SSA antibodies, at risk for having a fetus with congenital heart block? The answer to that question is complicated. So there's evidence that lower SSA antibody levels may be associated with lower risk. But many commercial labs just use a bioplex assay, which give crude estimate of ranges. It's like kind of like positive or negative. It's negative, it's less than 1 to 8, or greater than 8 usually indicates positive, meaning that there's sufficient titers to cause heart block, but that's not always the case, as I'm going to show you in a moment. And the commercial labs don't typically distinguish between the subtypes of the SSA antibodies, like Ro 52 and Ro 60. This is what our lab results look like at NYU, with just a patient who has positive antibodies, SSA antibodies. It just says that they're positive, greater than 8 AI, and that's it. But it doesn't give us enough information about what is truly their risk profile. So to look into this question a little bit more, I want to take a look at this study by Kaiser. It was published in AJOG in 2022. It was a multi-center study of pregnant people who had positive SSA antibodies. And they looked at the titers of antibodies at commercial labs, University of Colorado, Phoenix Children, and at NYU. And then they also looked at a research lab at NYU. And basically the question is, what concentration or what amount of titers predicts risk of developing heart block? So they stratified patients in this study into those who had no heart block in a current or past pregnancy, that was group 1, and then those pregnancies that were actively complicated by congenital heart block. So they had 66 patients in the study who currently had heart block, and we had the maternal SSA antibodies. Again, we did them by the standard commercial labs, they did them by the research labs, and then they also further stratified by the subtype of the autoantibodies, Ro 52 and Ro 60. These are the main results. I'll walk you through these figures here. So here we have on the left, which is the results of from the commercial labs, and on the right figure, you have the results from the NYU research lab. On the x-axis, you have the titer for Ro 52, and on the y-axis is the titer for Ro 60. And then the empty boxes are group 1, which is no congenital heart block, and group 2 is when you actually have the pregnancy complicated by heart block. And we're just plugging into here. We're showing what are the patients who have the high amount of Ro 52 and Ro 60, and the top right. We'll take a look on the left figure first. On the top right, those dark boxes, you see there appears to be a very clear threshold that when the titers of Ro 52 and 60 are, especially when they're both high, that's when we see the highest risk of babies developing congenital heart block. The same thing is true on the right side in the research lab. There are fewer patients there, but I've just shown here in purple. All of these patients have positive SSA antibodies, but they are not developing congenital heart block. And we can see there appears to be a threshold below which positive SSA antibodies don't appear to confer risk. So you have to have not just antibodies present, but high titers. And this study kind of clearly shows that probably half of people who have SSA antibodies, and we tell them that they are at risk for having a baby with congenital heart block, are probably not at risk. Now, we're stuck here because we all have access to commercial labs that don't typically subdivide the antibodies into row 52 and row 60. And they don't give us enough information about what is the true risk threshold. But I think it's worth noting that we can be reassuring in many cases for patients when they have positive antibodies. All right, so next question is, what is optimal surveillance and treatment? This is a challenging portion of the talk. There's so much data here, and I'm going to share what I think is my synthesis of the critical studies and what you need to know. We turn to the PRIDE study. This is the PR interval and dexamethasone evaluation study. This is a classic study. It was published in the American Journal of Cardiology in 2009. And it was one of the first big studies to give us information about the value of PR interval monitoring in the context of SSA antibodies. Patients included in the study they all had positive SSA and SSB antibodies. They had serial fetal echoes in the mid-trimester. And when they identified first or second degree block, they then rapidly treated with dexamethasone. And what you see in this multi-center, open label, non-randomized study, that majority of the patients, when they were identified with heart block, had third degree complete block, which I've already shared with this group. We have no intervention that's effective at making a difference. There was only 8 patients with first or second degree block. That's not very many to inform your management, but this is again one of the biggest and the best, and certainly one of the earliest studies looking at this issue. And here are the main findings of the study, sort of summarized. Prolongation of the PR interval often did not precede more advanced block. And when an advanced block and cardiomyopathy were found to occur, often within 1 week of a normal echo. So that's pretty wild. So PR interval monitoring at 1 week intervals, they suggest, is basically based on this, is not sufficient if your goal is to catch first degree block. In this study, data clearly confirmed that third degree block is irreversible. And it was really largely a negative study. I think some of my colleagues at NYU interpreted that even in the small cases of where we caught patients early enough with stage 1 or first degree block, that dex might make a difference. But really, I think the big impact of this study was to say PR interval monitoring at weekly intervals is probably not sufficient. And it does sort of create the landscape for studies looking at maybe home doptone monitoring is the best approach. And that brings us to stop block. I'll talk about stop block now. I think it's pretty obvious that an MFM wasn't directly involved in this planning of this study, because I think most MFMs hate the concept of home doptone monitoring, at least I do. But stop block is looking at that issue. It's called surveillance to prevent AV block likely to occur quickly. Stop block, and it addresses SSA antibody titers and the utility of home doptone monitoring with the goal, hopefully, of identifying first and second degree AV block so that we can get those patients in for treatment sooner, and certainly before it progresses to third degree block. In this study, subjects with SSA antibodies had commercial testing, but they were able to stratify the patients into high and low row 52 and row 60 titers. And then they sort of, based on the degree of the titers or the amount of titers, they determined what was going to be optimal practice. And in the high titer group in particular, patients between 17 and 26 weeks basically did 3 times a day home doptone monitoring, looking for any signs of a low or slow heart rate, with the idea that they would be rapidly moved to get fetal echoes. They also had routine echoes during this period every 1 to 2 weeks. But the idea was that as soon as there was even a subtle change on home doptone monitoring, these patients would rapidly get moved over to get a fetal echo with pediatric cardiology. Stop block was a huge undertaking with 22 centers across the United States. You keep in mind that it's just such an uncommon disease, and that is why you needed to have an infrastructure this broad to capture these patients. Here are the results. Sorry, it's a little blurry. They had 413 patients who had positive SSA antibodies. In the group 1, there were 152 patients who had low titers, who were not really, based on their what we think, high risk for AV block. And indeed, in that study, there were no cases of AV block. All positive SSA antibodies, but low titers, and none of those patients went on to develop congenital heart block. Group 2 is where the interesting sort of data is seen. There were 261 patients. All of these patients did the 3 times a day. Actually, some of them, 88 of them did I misspoke. All of them did 3 times a day Dopp tone monitoring, but some did weekly, some did biweekly echoes. Sorry about that. 3 times a day home monitoring. 251 of those patients went on to not have heart block in the pregnancy. 10 of them had heart block. Now, when we look really closely in those 10 patients who went on to have heart block, remarkably, Dopp tone monitoring seemed to identify them pretty well and almost always within 12 hours. There's a ton of data here. I'm sorry for this. It's really the normal field heart rate monitoring to abnormal FHRM column, the third from the right that I wanted to point out, and then the second from the right, where you see that the timeline from identifying a abnormal low or signs of a concerning rate at home to getting patients into an echo was almost always within 12 hours. So the stop block folks, the authors of this study, really conclude that home Dopp tone monitoring is helpful in identifying these early cases and getting patients into pediatric cardiology for echoes. By the way, they have 45 out of 30,000 recordings were positive, and 10 of those 45 had actual signs of AV block in the first and second degree. So again, I'm not thrilled about the idea of home Dopp tone monitoring, but it is at least some evidence from this study, which I think is hugely done and very big in terms of its scope, and its intent to capture small group of patients. But if we're going to do Dopp tone monitoring, what's the treatment? Do we have an intervention that's really effective at preventing progression of first or secondary block into complete block? Now, stop block is ongoing, and there is a protocol with treatment. I'll share that in a moment. But we don't know right now based on stop block. And if you look at all the data about early treatment, the truth is it's conflicting, it's case reports, it's bad. And it's really hard to tease out if truly early treatment, so first degree, second degree, or even when you see just AV valve regurgitation or some echogenicities in the crux of the heart, these are maybe early signs of neonatal cardiac lupus. If we treat at that point, does it really make a difference? The data is bad and unclear. Probably the best 2 studies I'll just share with you. There was a meta-analysis of 5 studies looking at early treatment with DEX. It says limited evidence as to the benefit. Probably not helpful. And then the PITCH trial, which I think is the best study of IVIG among patients with SSA antibodies. It used IVIG at replacement doses, showed that there was it did not make a difference in preventing recurrence of congenital heart block. So what do we do in these cases? Should we be doing home Dopp tone monitoring? Should we treat when we find early cases? Honestly, I just don't know the answer. But this confusion we take it a step further, has led to confusion among professional society recommendations. These 3 professional societies all have said that it is reasonable to do PR interval monitoring by serial echoes in the mid-trimester for patients with SSA antibodies. And then the Euler guidelines actually say, that's the European Alliance of Association for Rheumatology, that there should be consideration for home Doppler monitoring as well. Each one of these recommendations or these guidelines acknowledge that there's lack of data to inform treatment, but they say with shared decision-making, and given that this is a potentially devastating disease, that it should be considered. Now, I find that SMFM's guidelines are very reasonable. SMFM, to me, feels like the grown-ups in the room. They actually said that based on the data I've already shared with you, that we really should not be doing routine fetal echoes for patients with SSA antibodies, but that it's something that we can consider in the context of a clinical trial. This, by the way, this is, I find this to be a really reasonable recommendation, but it did make the stop block designers very, very unhappy. Many of these colleagues are from NYU and from across the country and actually across the world. This is a commentary that was published in AJOG, basically right after SMFM's expert series came out that said we shouldn't do routine PR interval monitoring for SSA positive patients. And they say knowledge is power and that surveillance should be an option for patients through shared decision making. And they're upset because if SMFM says we should not do this type of surveillance, then MFMs are not doing this type of surveillance. And then there's questions about insurance and who's paying for it. It's really a real problem. And they're very, very upset that that SMFM took this stand and does not align with these other professional societies. I think when I put it all together is, like I said, I really don't know what is the best approach. Stop block continues to recruit patients. They continue to give home doptone monitoring for plans for patients with high titers with SSA antibodies. And the idea is as soon as they identify early signs of cardiac lupus, early changes, even before third degree block, that these patients get in for treatment. This is actually their fairly complex protocol for IVIG and for DEX. I think when this study comes out, and if it comes back and turns out that it's a positive result, then it may actually support doing home doptone monitoring and with the goal of early treatment for these cases. But if this study comes back negative, it would just add to a body of literature that's already conflicted, but says that it's probably not effective. And then I would say that SMFM's guidelines are right on. All right, so that's part 2 of my talk, and I'm going to jump into the third part, which I think is one of the most interesting part, and where I'm going to share some new research we're doing. The question is, patients who have a prior affected baby with congenital heart block, we believe those patients are highest risk for recurrent heart block in another pregnancy. What do we do with those patients? I think the best data to inform our practice comes from the PATCH trial, and it's worth taking a few minutes to just talk about it. It's a multi-center, open-label, single-arm, 2-stage study. The idea was, does Plaquenil, if started prior to 10 weeks gestation in patients who had a prior affected pregnancy, prevent or reduce the risk of recurrence? It was published in 2020 in the Journal of the American College of Cardiology. And here are the main results. They looked at those patients who had prior affected pregnancies to calculate a historical rate of recurrence, which was about 18%. Again, all of these patients then were on Plaquenil in the next pregnancy. It all had to be started prior to 10 weeks gestation. And what they found is the rate of recurrence was substantially reduced. So in an intention treat analysis, 7.4% of these patients, all with high titers, by the way, and a prior affected baby, who had early changes of congenital heart block, had that was the rate of recurrent heart block. So 7.4%, basically a 60% reduction. That per protocol analysis also showed about a 60% reduction in recurrent congenital heart block. Again, it supports that, at least in this study, despite its limitations, that Plaquenil started prior to 10 weeks might be the best approach. The study has its limitations. It's not randomized. In order to do this study as a randomized clinical trial, you have to have probably about 1/2 of the group would have to be placebo, and you'd need at least 100 patients in each arm, which make that just impractical. Some patients received confounding medications as well. There were some who received DEX and IVIG. But with those limitations in mind, we just have, I think probably best available data says if someone has a prior pregnancy affected by congenital heart block, starting Plaquenil prior to 10 weeks should be considered. But I really think we need a new approach. We need a novel approach, we've already said there's no cure for heart block when it develops. We know that high titers are necessary to cause heart block, but many patients who have high titers don't go on to develop congenital heart block in their fetuses. And it's exciting that there's this new novel strategy using FC receptor blockade that can prevent antibody transfer that could be applied in this area that might be all of the difference. So there's 3 interesting developments that have happened in the last couple years that I think set the stage for a really exciting new study. And I'm going to go through those 3 developments now. So development number 1. So we know that neonatal FC receptor mediated placental transport, basically when the antibodies are crossing the placenta through use of this receptor, it happens at a much, much higher rate in the 3rd trimester than in the mid trimester. Okay. So if these antibodies, these SSA antibodies, are the causative agent that leads to congenital heart block, we really need to have proof that there are high circulating antibody levels in the fetus in the mid trimester. So we actually did this a very small study. We published it in Lancet Rheumatology just this year. We had 3 babies, 3 pregnancies complicated by congenital heart block. I think all 3 were hydropic in the mid trimester, and basically these babies were dying. And they elected to terminate their pregnancies. They gave us permission to collect fluid from the cord bloods and serosal fluids, and we also had some maternal samples as well. And we were actually able to quantify the titers of row 52 and row 60 antibodies in the fetal tissues. And the results are shown in this table. I'll summarize it and to say that all 3 of these fetuses had extremely high levels of SSA antibodies in these tissues at the time of their termination, again, in the context of high drops and complete heart block. And it's remarkable that these levels were so high, and they were only 15% or so of the maternal amount of antibodies. So this first development kind of fairly clearly shows that the antibodies, even though they don't cross that well in the mid trimester, they cross well enough and at high enough concentrations to be in the fetal tissues and could cause problems for the fetuses. So that's development 1, again, laying the groundwork for the use of an FC receptor blocker therapy in this area. Number 2, the second development was the exciting publication of the Unity trial in the New England Journal of Medicine last year. If all the MFM fellows have not read this paper, and if others have not read it, it is a great read and really remarkable and worth looking at. So nipocalimab is a neonatal FC receptor blocker. This is Ken Moyse's study, by the way. His very first study had 13 patients in the New England Journal of Medicine, and so did this one, which is, I think, his last New England Journal of Medicine paper. But what they did in this case is they gave Nipo to patients who had had prior pregnancies complicated by hemolytic disease of the fetus and newborn. This is a disease that is similarly caused by maternal antibodies that cross the placenta and cause negative effects in the fetus. So patients got Nipo from 14 to 35 weeks. There were 13 of them. All had pregnancies previously complicated by hemolytic disease of the fetus and the newborn. And then the results I will share with you now were quite exciting. All right, so the primary endpoint was live birth at greater than or equal to 32 weeks of gestation without requiring an intrauterine transfusion. Among the patients that received Nipo, 54% of them met the outcome. They had a live birth after 32 weeks without a single transfusion. And when you look at Moyse used the prior pregnancies of these patients, the prior affected pregnancies as the comparison group. They call that the most recent qualifying pregnancy. 0 in that group who obviously before they received Nipo were able to get to 32 weeks without an intrauterine transfusion. Going down the list a little bit more, live birth, among the patients that received Nipo, all 13 of them, 92% had a live birth compared to 38% in the prior affected pregnancies. Median gestational age at delivery, for the NEPO-exposed babies was 36 weeks and 5 days compared to 33 weeks. The median number of intrauterine transfusions was 0 in the NEPO group compared to 5 in the previous pregnancies. And the data just continues to just look remarkable. The median gestational age of delivery was 36 weeks and 4 days compared to 23 weeks. Number of transfusions, 6 compared to 11. It was 46% had greater than 1 transfusion in the NEPO group compared to 85% in the previous unexposed pregnancies. So really compelling data. I understand it's the limitations of this study. It's basically a large case series. So we had 13 patients, but it really supports that if we can block these putative antibodies with FC that go through the FC receptor, we can make lower concentration of the antibodies and impact this disease and probably congenital heart block. And then finally, I'm going to share this data, development number 3, again, laying the groundwork for what I hope will be an exciting trial. Rozanoliximab, Rystiggo, is a medicine that's FDA approved for myasthenia gravis. It is a neonatal FC receptor blocker, and we have some data that it is safe for use in pregnancy. This was just published this year, and reproductive toxicology. So 3 sort of developments laying the groundwork for the use of neonatal FC receptor blockers in congenital heart block, which leads us to the work that we're doing now at NYU and beyond. I'm going to share with you guys the AVERT trial, which we just submitted to the NIH for funding. It's atrioventricular block elimination with roxanoliximab therapy, or AVERT. My collaborators are Jill Jill and actually Bettina Cuneo. These 2 in particular are probably the leading experts in congenital heart block in the country, if not beyond. Jill's a rheumatologist. Bettina is a pediatric cardiologist. Also, from rheumatology at NYU, we have Bob Clancy, and then we have our epidemiologist, Mimi Kim from Albert Einstein. And this is a multi-PI study, and really excited to share it with all of you. We're looking to see if Rystiggo, this medication, I'll call it Rosie for short, and hydroxychloroquine can prevent or reduce the severity of congenital heart block in patients with prior affected pregnancies. It is a single-arm phase 2 open-label trial. And we're going to include patients, again, who've had prior affected pregnancies with congenital heart block and high circulating SSA antibodies. All of the medication will be donated by the company that makes it, UCB. This medicine in particular, as an FC receptor blocker, actually works by 2 mechanisms. It prevents IgG recycling, so it actually increases the rate of degradation of maternal antibodies, so we have less circulating antibodies in the mom. And then it reduces placental transfer of these antibodies, so we have less exposure to the fetus. So it's a double benefit, which we are excited to see in use. Our goals of the study are listed here to determine whether Rosie and Plaquenil are effective in reducing and preventing the recurrence of 2nd-degree and 3rd-degree heart block. We'll also evaluate the impact of the medication on the antibody levels and determine a safety profile of this medication. And again, our hypothesis is based on the paradigm. If there's no antibody, there will be no disease. So we hypothesize that by lowering the concentration of the antibody and reducing exposure to the fetus, we should avert this terrible disease. These are our primary outcome. These are inclusion criteria. I've already mentioned prior affected child, high circulating levels of SSA antibodies. Patients have to be on Plaquenil prior to 10 weeks to be enrolled. Our primary outcome is recurrence of 2nd and 3rd degree block. And this is sort of the meat of the study, where we think, based on patch, the recurrence risk is about 8%. We're thinking that with the intervention, recurrence might be around 2%, and assuming an 80% power and a one-sided alpha of 5%, we're going to need to recruit 89 patients. We're using a Simon's 2-stage optimal approach, which is, I think, important when we have such small numbers. In stage 1, we'll enroll 35 patients from across the country, and if 2 or more subjects have a child or a fetus with 2nd or 3rd degree block, then the study will be terminated for inefficacy. But if it's negative and we don't have any affected, or one or more, we don't have 1 or more affected, we will continue into stage 2 and enroll an additional 54 patients. And we're going to leverage the infrastructure of StopBlock for this study. This is just the plan as illustrated in this figure. patients will come in and get started on Plaquenil, again, prior to 10 weeks gestation. We'll be using Rosie weekly, starting at 14 weeks up until 25 weeks. We're covering that mid-trimester vulnerable period. Patients will also be doing home doptone monitoring. The rheumatologists feel very strongly about this between 18 and 25 weeks. We'll be collecting maternal blood. We'll be doing cord blood and infant blood after exposure. And we are extremely optimistic about this study. We did submit this to the NIH, as I mentioned. We scored very, very well. But there's so much uncertainty. It's an NICHD grant. We don't know if we will ever be funded, but I certainly hope that we will. And there will be more to come about this study. So that leads us to just my conclusions. Not all people with SSA antibodies are at risk for congenital heart block. Steroids and IVIG may have limited roles for first or second degree block. We just really need more study, more evidence to support these approaches. And I don't have the answer about optimal surveillance. I think it's going to be an individualized approach. I think in patients who have a prior affected pregnancy, those patients should be started on Plaquenil or hydroxychloroquine in the subsequent pregnancy and before 10 weeks of gestation. And I think FC receptor blockade is the future in this space. And I hope you all stay tuned for more results about this trial. Thank you. Again, thanks to everybody here for listening. I would like to acknowledge my collaborators, Jill and Bettina and Mala in particular, but I'm happy to take any questions.
Thank you, Dr. Brandt. That was excellent. So interesting. I see that Dr. Sharma has her hand up.
Wow, Justin, this was amazing. Very, great talk and very thought-provoking and exciting work ahead. There is clear biological plausibility. The questions, I have many questions, but I'm going to start with one. And so you shared the animal data, right? That's the basic, we have the some proof of concept there. What do you foresee as, are there any safety concerns with the drug? And do you foresee any barriers to adoption?
Yeah, I think there are concerns. So I'll tell you something I'd like to keep quiet with the group, but we got an IND to treat a patient with lupus who had 2 prior affected pregnancies with this medication. She had a pregnancy that was complicated by actually cutaneous lupus in the first pregnancy. And in the second pregnancy, the baby developed heart block and actually died at 24 weeks in the context of hydrops. And in the third pregnancy, this baby had developed congenital heart block, made it to 35 weeks, and then had a delivery, and the kid got a pacemaker and did fine. So this is her 4th pregnancy, and she came to us early, and we treated her with this medication. It's an N-of-1 study, and it's given us a lot of insight. She was also on Plaquenil, and her immune system has just really plummeted. And it's not clear, was this a manifestation of lupus? Is this a manifestation of Plaquenil? How is the contribution of Rystiggo, which causes the maternal IgG levels to drop? It's been really uncertain. We followed the protocol from the Unity trial to some extent, and we do have a plan to replace basically immunoglobulins as needed, but we haven't had to do that yet. But so this N-of-1 study has given us real insight into risks, some related to the medicine, some related to just the disease that is lupus, and it is challenging. But I've also known that now that I've been at NYU and I've seen all of these patients with history of congenital heart block, when they come back to you, they are desperate to have a better outcome, and they're willing to expose themselves to a certain amount of risk. The limited monkey data suggests that these babies' immune systems do well, and that there's no risk of malformations, but it's really incomplete data.
Yeah, I see a lot of hands raised, but I'm going to ask one more question now that I have the mic. You showed that patch trial showed some benefit of hydroxychloroquine. So in this study, you're going to combine it with with your drug, right? So how are you going to isolate the beneficial effect? Is it due to hydroxychloroquine or?
All patients will be on hydroxychloroquine. So that was actually a big discussion for us when we talked about the designing of this study. The question was, is hydroxychloroquine the standard of care for patients who have a prior affected pregnancy? My rheumatology colleagues were like, absolutely. As an MFM coming into the space, I'm like, I don't think that's clear. We have one good study, and I'm using good kind of respectfully. It's not a great study, but it is the best that we have. But I think from coming from our group that has all this experience, they did pitch, they did patch, to not start patients on Plaquenil would have been a mistake. And I do think patients coming in prior to 10 weeks should be started on it. And then we'll see the added contribution of Restigo. If we assume patch showed us an 18% to 7 or 6, it was about a 7.5% reduction. So it's a 60% improvement. Then we're hoping that we're going to see further reduction with the FC receptor blocker. Ruchira, what is your perspective on Plaquenil? Do you think it's the standard, or do you agree with me?
I mean, the thing is that all the lupus patients, it's hard to do that study with no Plaquenil, because all the lupus patients are pretty much on it, because it's gonna reduce the frequency of flares. So
Absolutely.
I think it's feasibility wise, it's a good approach.
Right. And there will be some confounding with these other medications, though. Dr. Rosen says that he does Plaquenil too. I think it's the best approach. And your point is right. Most, if not all, lupus patients will be on Plaquenil in pregnancy.
I see that Dr. Rosenfeld has her hand up.
Thank you so much for a really thought-provoking presentation, and it's just so exciting to see everything that you have been doing at NYU. I was also going to ask about Plaquenil just because it is standard of care for everyone with lupus. But like Ruchira, I have a number of other questions. If we want to run like actual SSA titers to see who is at risk, is there a lab that we can send it to? Do we have to call the lab? Is there a way to get that information?
Honestly, I don't know what's available in New Jersey in terms of local labs. And I think you'd have to make some phone calls to figure that out. I know that we're very open to helping patients with SSA antibodies as part of our stop block team. And I'm sure if you have a patient who's positive, we could help run those labs. But I don't know what's available in New Jersey.
I see that Dr. Patrick has her hand up.
Hi, good morning. Justin, thanks for a really good talk. I actually just had a patient with positive SSA antibodies come for a consult a couple weeks ago, and I wish I had heard your talk before I did her consult. I actually had the same question as Dr. Rosenfeld, and then my other question was, for patients who maybe it's their first pregnancy or don't have a history of a baby or a fetus impacted with heart block, is there any data about use of Plaquenil and heart block in those patients? Because I'm having a lot of people, like the patient that I saw recently didn't have lupus and was not on Plaquenil. She had another autoimmune condition and was asking my opinion about that.
When I put together this presentation, I thought I would really delve into some of these studies, looking at the various medications. And then I got fed up with it. I said, there's so much conflicting data. There's so many small studies. There's nothing of high value there. So the answer to that question is it's not clear if it's beneficial. And I don't know the right answer at this time. I think this is the challenge of studying a very rare disease. And if we could tease out who are truly at risk, that would be the first step in identifying who we need to treat more effectively. But most patients, half of patients have low titers, but they're positive, and we treat them, what does that give? What information are we getting from that?
I see that Dr. Rosen has his hand up.
Justin, thank you so much for a really provocative talk, and I think your trial makes all the sense in the world. Actually, Dr. Rosenfeld's going to be running the nipocalimab FNATE trial here at Rutgers, and mostly for the state of New Jersey, which we're excited about. Because of the rarity of the disease, I actually approached Janssen J&J about whether we could use that drug, and they were like, nope, too rare, like you said, the incidence is like less than 1 in 10,000, I think, in the population. And they're like, there's no money in that. It's far less than NATE or hemolytic disease of the newborn. And maybe you guys already had those conversations with industry, but they were not excited about the trial. This is the one, my one comment. I love your talk, and I want to figure out a way to run those antibodies so we can do the things you're doing. But my question is, like, going back to like the clinical practice part of your talk, you were talking about controversy in the management, and I know that our governing bodies have different opinions, but there's no type 1 evidence at all that therapy works. And steroids are potentially harmful. You didn't talk about like the like increasing amount of that childhood development, mental acuity, behavioral problems are twice as common, give or take, in children who are exposed to dexamethasone in much lower doses during their pregnancy. In the big Finnish study that was published in JAMA in 2020, the incidence rose by school age up from 4% to closer to 10% in that study. So I'm going to ask, with no proven benefit and real risk to these types of therapies, to the steroids especially, why is there controversy? Like, why are you uncertain of what to do? Like, to me, the answer is clear right now. Like, you guys need to find a better treatment, and you're doing that, and God, that's amazing. But right now, why would you give steroids to anybody with?
Yeah. I love your question. I think it's an important point. I've never felt in a clinical space as engaged with anecdote as I am in this space. But I think you're right. I think our rheumatology colleagues, our pediatric cardiology colleagues, they favor treatment aggressively because we're often confronted with a sick baby. So I think in the context of like early heart block, the risk benefit ratio is just different. Treating with Dex in a patient who has no affected babies and who has no signs of cardiac neonatal lupus makes no sense to me. I think the risk benefit ratio says we shouldn't be using it. But I have been thinking a little bit differently in the context of an abnormal fetus in front of us. When the risk of dying is high, the risk of high drops preterm birth is high. And so that's the answer. But I think you're right. There's no level 1 evidence. We're really, I could have said it, you said it much better than me, but the controversy is really, we're just living an anecdote. And this is not the way we should be practicing most of the time.
Yeah. And just to follow up what I said, and thank you for the answer. Like, for me, in any clinical situation, this one or anyone, no proven benefit, proven risk, it is unethical, and we shouldn't be doing it no matter what the rheumatologists say. Justin, it's just a different.
By the way, that is the way I practice. That is what I teach my fellows. I think that is a critically important point, and I appreciate you mentioning it. When that first patient I mentioned who was having congenital heart block came over to me, she had already been started on Dex, and we know it's not effective, and I just couldn't believe it. So I don't use it myself. I think, again, in the context of these early changes, really we should be waiting until we have the results of stop block, because that is going to provide some information about early identification, early initiation of treatment, and maybe it makes a difference. But you raised very, very good points and an important teaching point.
With just 1 minute left, Dr. Sharma has her hand up.
Sorry, Justin, I have a million questions. I think one point that you clearly made was one case that you clearly made was the call for like standardized quantitative antibody testing. Is that something we should be pushing for at a national level, that we should be doing?
It is. We're just put together an abstract for the American College of Rheumatology meeting where we have all these different commercial labs, and what we are doing is actually showing the negative predictive value at the positive titer for the different commercial labs, and that's not what we should be doing to identify risk. We should be having a standardized approach. So that was my conclusion in when I reviewed that abstract, and I hope that's what we'll be saying more. But I think you're absolutely right. There should be a more standardized approach that is titrated to a perceived risk threshold.
Dr. Brandt, thank you so much. This was great.
This was very fun for me. It was great to talk to all of you guys. I miss you all very much, and thank you for the opportunity to come talk today.
Thank you. We miss you too. All right.
I
Well,
guess.
thanks everyone. With that, we're just about out of time, so we must end. But I hope everyone has a safe and successful day.